is the importance of diagnosis? Or what is the relevance of diagnosis? Why you have to diagnose precisely? Why? Because you can identify the pathology. The pathological process inside the body can be identified when you do a precise diagnosis. So the diagnosis is again practically in our practical medicine, it is classified into uh, etiological diagnosis and pathological diagnosis. Pathological diagnosis means a patient with a dyslipidemia. It is that name itself is given on the basis of the pathological process happened in the body, because the lipids of the patient is increased. The level of the lipids of the patient is increased above the normal limits. So it is called dyslipidemia, and that diagnosis is based on a pathological condition. So it is called a pathological diagnosis. So pathological diagnosis, and again there is a type of diagnosis. It is called etiological diagnosis. Etiological diagnosis means that that diagnosis will be telling the etiological factor, the causative factor. For example, the COVID-19 SARS virus, COVID-19. So that diagnosis itself indicates the organism which causes the condition, the disease. So there is a etiological diagnosis. Anyway, the investigations or the diagnosis will be giving you the pathology and at times the etiology also. And the most important thing is that when we handle a case, when we handle a patient, when we see a patient, he will be telling you some complaints. Then naturally you will collect so many clinical database, and on that clinical database, you will have a running diagnosis or a provisional diagnosis or a clinical diagnosis. With the history alone, you will have a clinical diagnosis. And with the investigations, you can have a confirmation on that diagnosis. You can have a confirmation on that diagnosis. For example, you have diagnosed that the patient is having that if the patient is having one particular condition, diabetes mellitus. On the basis of the history and all, you come to the conclusion that the patient may have the type 2 diabetes. And on the evaluation, you find that the glucose level is increased, the A1C level is increased, so you can confirm the diagnosis. You can confirm your running diagnosis or a clinical diagnosis. That is the importance of this investigation in diagnosis. And definitely, the most important thing is that we can identify the prognosis also in many conditions. For example, a patient presented to you with liver CA. He was presented to you with some liver disease symptoms, and on evaluation of that condition, you come to the conclusion that the patient is having that hepatocellular carcinoma by seeing the alpha beta protein, the marker of the hepatocellular carcinoma, and you diagnose the case. There is a confirmed case of hepatocellular carcinoma. Then the prognosis can be predicted. What will be the course of illness? What will be the prognosis? What will be the life expectancy of that patient? Everything can be predicted from this diagnosis. So to know the prognosis, it is very fine. Or in a simple case of type 2 diabetes mellitus, you can see the prognosis. Why? Because you can say that it is not a curable disease. It is a AIAPGET disease only. The patient has to continue the medicine for lifestyle modification, whatever it is, to the end of the life. And so on, you can understand or you can explain the prognosis to the patient. So to identify the prognosis also, it will be helping us a lot. And the most important thing is that whenever we have a diagnosis, always you should have or you must have give some differential diagnosis. Why? Because always you never go back to a single diagnosis. You have to consider other possibilities which may have the same type of symptoms or the same group of symptoms or something like that. So, but that can be differentiated by a investigation. For example, a patient presented with polyarthritis, with the painful joints, multiple joints, painful joints, with some maybe with some history of fever or without history of fever, and morning stiffness may be there, may not be there, and with the atypical symptoms of many type of means like reactive arthritis maybe, or maybe rheumatoid, or maybe some other systemic diseases. So anyway, you diagnosed the case as your running diagnosis may be polyarthritis under evaluation, but on the in the investigation you find that the anti-CCP antibody of that patient is positive. Then the thing is that you can have a final diagnosis of rheumatoid arthritis. So up to that level, you should have some differential to be keeping here. For example, the ESR may be around 100, the CRP may be around 40 or 60, and other blood parameters may be that denoting the inflammatory process of the body. But in that point of time, we cannot make a final diagnosis. So you have to keep a running diagnosis, and you have to take final diagnosis. For this diagnosis, the investigations will be helping you. So that is very important. So anyway, this all denotes the importance of diagnosis in clinical practice. So what do you will do for a better diagnostic process? Diagnosis is a process. Diagnostic process is a very serious, very important process in our clinical practice. So how we can make a better diagnosis? So this is the basics of clinical medicine, but uh, but you have to be very cautious or very particular always in your clinical practice regarding the basics of these steps in diagnosis, because otherwise we can say it as we can forget the term diagnosis, but evaluation of the patient. If anybody comes to you, any patient comes to you, you have to evaluate. For example, LVA under evaluation, pain under evaluation, or jaundice under evaluation, fever under evaluation. All these type of presentations, clinical presentations, will be coming to our clinics or our consultation facilities. Then naturally there is the risk of or the effort of the clinician is to have a better diagnosis or a precise diagnosis. So my my humble advice is that always you have to be very particularly do a systematic evaluation. The systematic evaluation is very important for yielding a diagnosis. What is systematic evaluation? Systematic evaluation is nothing but the steps in diagnosis should be followed meticulously. Meticulously means without any error. If at all you are in a busy clinical setup, or you may be in a busy mode, or whatever may be the setup, clinical setup, you have to do a systematic evaluation of that patient. Then only you will get a better diagnosis or a precise diagnosis. So these are the components in diagnosis. As you know, everybody knows that the participants, everybody knows, and you are making you are doing this activity on each and every moment of your professional life. But again, you think of you have to take a meticulous history. Meticulous history means, see, history taking is an important skill acquired by a clinician. It is a skill. History taking is a very important skill to be acquired by a clinician. Why? Because while taking the history only, we clearly identify the concern of the patient, and the patient perception, the views of the symptom will be different from the clinician. But anyway, the history should be taken meticulously. History means the complaints, but the complaints very clearly, very clearly, very listenedly, very attentively. You have to hear the story of the health history or the complaints or the concern of the patient. So that history taking is very important. Um, and in that history taking, naturally there are some components like complaints, the history of the complaints, and naturally if I have to put some question on the past health of the patient, and definitely you have to ask about the family history of the father, means of the mother, the father, the siblings, the first degree relatives, the second degree relatives, and everything should be just questioned. And personal history also. The personal history, in that personal history, we will get so many Ayurvedic variables on the Nidana or the etiological factors. And so that personal history also should be elicited. And in the case of, as you know, in the case of females, if the females are an adult, then naturally you have to have a history on the reproductive health and all. So anyway, that steps should be followed in a semantic way. Why? Because there is no difference in Ayurveda and modern medicine or the current medical system regarding the history taking. So that history taking will be giving you a running diagnosis or a provisional diagnosis or a clinical diagnosis of accuracy at 80% level. We can diagnose most of the cases, means 80% of the cases can be diagnosed provisionally, or you will get a very good running diagnosis of the patient. And it is calculated that it is reported that it is studied that 80% of the patient's diagnosis can be made from the history taking alone. So that history is very important. So with this meticulous history taking, you can go for the next step, that is examination. See, in the time taken for this history taking in comprehensive cases and in the simple cases, that means the long cases and short cases. For example, a patient presented with a fever and cough, 3 days duration, and there is an epidemic of this viral fever in that area. In that case, the questions will be different, and in that case, all these components of history taking may not be relevant in that way. That importance. So in that area, we can have a short module of the history taking with the relevant questions, with the epidemiology questions and that. But in the case of some other neurological disorder or some musculoskeletal disorders or some GET disorders or liver disorders, you have to take a comprehensive history. So that is very important. Naturally, there is a difference between these short cases and long cases, means comprehensive cases. But we have to think on the basis of the comprehensive history taking of the major cases only. And examination. Coming to the history, after history, anyway, you have a diagnosis in your hand, a running diagnosis in your hand, and then the system which is affected is very clear. And naturally, you have to go for the examination. And examination always, the general examination is very important, and you have to read the test books again and again. You have to see the patients again and again. You have to keep the findings in your mind, the examination of the hand, the clubbing, the pallor, so many things you have to keep in your mind. And if anyway, after this, even the height, weight, everything is very important. And after general examination, you have to do a thorough clinical examination of the system and the associated systems, whatever we need in this particular patient. So that examination skill is very important. So this is the most important second skill in clinical medicine. The first skill is to take a history, to elicit a history. That is very important. everybody when hearing that, oh, history taking is oh, that is simple because we are doing in a daily basis with seeing so many patients. But in every day you have to try for an improvisation in history taking, so that your perception towards the diagnosis, your intuition towards the diagnosis will be improving a lot. So, history taking is not a simple thing. So, eliciting the history is a most important skill of a clinician. And naturally, the second one is examination. In examination, you are going to verify the pathological processes that you might have think about. For example, the patient presented with a liver disorder, and you may have an assumption that the patient is having some cirrhosis liver. Then you will expect some findings on the patient. In general examination and the systemic examination, you will expect some findings on the patient. Or, for example, in some other patient, the patient may have a stroke or a post-stroke. Then you know that the CNS is affected and the areas of nervous system affected is very clear, and the stroke is maybe there are many types. Even though there are many types of stroke, if the patient is having classical stroke, while going for examination, you are having some idea, and that you'll find that these are the findings that I may get, or we will anticipate some findings from the patient. So anyway, we have to do a better clinical examination. That is very, very important. With all this history taking and examination, your diagnosis is almost completed. Then the next portion, that is investigations. This is the most important area. That in that area you are going to confirm your diagnosis, or you are going to confirm the risk factors of the diagnosis, or you are going to confirm the etiological factors of your diagnosis, or you are going to confirm the prognosis of the diagnosis, means the prognosis of that particular patient or that diagnosis. And uh, you are you're going to evaluate the or assess the efficacy of the treatment. For example, by investigating the case, we can assess the treatment also. Not only the course of the disease can be predicted, but we can also ask the management also. For example, by in a diabetic patient, in a cardiovascular disorder, a hypertensive patient, in all these type of patients, we can utilize the investigation or dyslipidemia. Dyslipidemia is only the result is most of the time the result is only depending on the investigation reports only. So in all these things, you can for all this purpose also you can do this utilize this investigation. So these are the steps in diagnosis, and by doing these components in a systematic way or by a systematic approach, you can have a better diagnosis, no doubt. But this is not a simple job. It is the most tedious job of the clinician, because if the clinician is able to diagnose it better in a better way, uh, the management is very simple. Why? Because in the modern medicine or in Ayurveda, all the textbooks are giving uh, particular guidelines or pakka guidelines, means very clear guidelines for the management of most of the diseases. So treatment is very simple. Pharmacology is very simple because we know that. But the skill of the clinician or the breadth clinician needed is for the diagnosis. So always, once again, and always I say that you have to make a better diagnosis to become a very good clinician. You should be very particular that you have to, in each and every case, without diagnosis, you never treat. Without running diagnosis, you never treat the patient. And for the diagnosis, you should have some rationale. You should have some basis for your diagnosis. Always, you should have some basis for your diagnosis. If patient asks you, or or some authorities ask you, or if your peer group asks you, or if you want to refer the patient to somebody else, then also you have to have a diagnosis. So for all every purpose in clinical medicine, you want a diagnosis. So always you have to be to try for a diagnosis, a precise diagnosis. Don't satisfied with the first diagnosis itself. You have to verify it. You have to verify and reassess the diagnosis. Then, if you continuously do this process and if you are very particular in diagnosis continuously, then after 5 years or 10 years in your professional life, you will be a very good clinician. That is the thing. Because in clinical medicine, every day we are learning. Every day we are learning from the patient and from the, because some science once in a life only, once in our professional life only, we will be seeing a particular sign, because we will get that patient at that time only for a spindle hemorrhage in bacterial endocarditis. Maybe we will be seeing once in only once in our lifetime only. So many findings, clinical findings will be getting very rarely, and so many clinical findings will be getting daily or mostly most of the time. So anyway, you have to be very particular in diagnosis. Then what? Then naturally there is a question that what is the use? You have made a very good diagnosis, and the next discussion is that naturally the question is that what is the use of all these modern diagnoses in Ayurveda, or what is the utilization of these investigations in Ayurveda? It is a very interesting area. I would like to say that in the in the diagnostic part, or in the clinical medicine part, there is no difference between Ayurvedic and modern the contemporary sciences in the assessment of the patient, in the evaluation of the patient. We can utilize whatever the advancement the science is, the science and technology is coming up with. Because in the case of simply, if we explain the thing, see, I will be coming to the next slide for that. See, when we look into Ayurveda, the main tools for diagnosis in Ayurveda is Roga Pareeksha, Yogi Pareeksha. Everybody knows that Roga Pareeksha, Yogi Pareeksha. What is the tool for examination in Ayurveda? Nothing simple. Roga Pareeksha, Yogi Pareeksha. And what about Roga Pareeksha? Roga Pareeksha is of five types: Nidana, Pururuga, Ruga, Upasya, and Samrati. That we know. And this is nothing but the history take, the scheme of history take. But only thing is that we will be starting at the level of Ruva or the symptoms, signs and symptoms, and we will be retrospectively going back to Pururuva and again to Nidana in the steps of history taking. uh, Means in the first component after the identification data, what we will be asking to the patient is that what is the problem with you, what are the concern of you, or for what purpose you came to me. So all these questions are um, uh, in favor of the rupa. We are going to elicit the rupa, the complaints for the symptoms. Then after getting the symptoms, we are going back to Ururuva. Oh, how it is started? How many days back you was okay? And how was it started? In that area, we are looking into the Ururuva. Then coming to the other parts of the story, the previous health, the family history, previous health determines the predisposition of the patient to have such disease, if any. And then family history, we are looking into the Bejadushti or the hereditary factors which may cause for the predisposition of the patient to have this disease. So all this comes under, and definitely the personal history. In the personal history is very particularly we are eliciting the aharas and viharas. So nidana, all these categories are nidanas only. So rupa, pururupa, nidana, we are going back to up to nidana. And again, see, there is a very beauty of this Roga Pareeksha, that Upashaya. Upashaya is nothing but, that Dosha Doshi Samurtana is happening. Dosha Dusha Samurchana stage also we are having so many diagnoses in the present scenario. For example, so many biochemical that diagnosis, pathological diagnosis. For example, dyslipidemia diagnosis, for IGT, impaired glucose tolerance, or pre-diabetes diagnosis. In all these conditions, the disease is not too much manifested, but these are pathological diagnoses only. And for example, some patients will have this HbA1c positive, but the symptomatic. We will call it as chronic hepatitis patient. uh, Means it is a group of patients, those who are having positiveness in the hepatitis marker, but the symptoms are not there. In all that conditions, it's an overshare diagnosis. And naturally, another thing is that with all these Nidana, Ruga, Pururuga, and all, we can develop the pathological process also we can assume. So it is some bragging. And Ubasha is nothing but if we are in a deadlock for a particular diagnosis, we can start with some treatment. We can go for screening our diagnosis with the therapies also. We can utilize the management also for a diagnosis. That also is for diagnosis. And the same thing which is mentioned in the modern medicine or the current medicine as for history taking is mentioned as it is in Roga Pareeksha in Ayurveda. And then coming to the examination or Rogi Pareeksha, there are different types of Rogi Pareeksha in Ayurveda, from Divida Pareeksha, Trivida Pareeksha, Chaturvida Pareeksha, then Shadvida Pareeksha, then Ashtasthana Pareeksha and Dasavida Pareeksha is of different types of Dasavida Pareeksha. So, see, there are many type of examination methodologies in Ayurveda, from Divida to Dasavida. Why this type of multiple type of examination was mentioned means in certain period of time the acharyas were very particular in the examination of the patient. And without examination, we cannot have a diagnosis. Without a diagnosis, we cannot have a management. The management is the one of the most important what we can say the objective of the science. So Yogi Parisha is explained in a different way. That the same Yogi Parisha is we can if we look into the current scenario, Yogi Parisha is nothing but the examination of the roles, examination of doshas, doshas, and so many other things. As you know, every type of exam in these type of multiple level, multiple examination methodologies, uh, it is giving emphasis to examination only. And so in this context of Roga Pareeksha and Rogi Pareeksha, the current investigations we can be utilized in the dosha Dushyadi Pareeksha. Dushyadi Pareeksha means I'll be coming to that slide. For example, if the patient is having a Raktavasrodha Dushti Roga, then definitely we can explore the Raktavasrodha Dushti to a specific to a meticulous way by utilizing the various evaluation in relation to Raktavasrodhas, like a liver function test. Liver function test itself is highly yielding to the dushti of the Raktavas rodents. Or, for example, in the case of Rasavas rodents, in the case of Rasavas rodents, we can have so many hematological markers for identifying almost all type of Rasavas rodent yogas you will be getting Amalakshana standard. And we had conducted a study regarding the biomarkers, the to develop an objective parameter to assess the AMA, uh, and we utilized the CRP, the ESR, and the other total WBC and the differentials. And it is observed that in Amavasta the inflammatory markers will be elevated. So there is a direct relation between the Dushti and the investigations, which is mentioned for acute that inflammatory condition in the current system. Uh, like this Rogas, we can utilize the that hepatobiliary system investigations we can do in the Rogas. In Rogas, we can utilize the CPK level or the EMG studies and all. We can utilize the enzymes which is giving the normal or the normality of the activities of the physiology of the muscle tissues. So that can be utilized. That can be utilized in that way. And even in the metabolic process, we can see the lipid level of the primary level. At primary level, we can utilize the lipid mechanism, the assessment of the lipids, and everything or indirectly some other parameters also we can utilize for the assessment of the Medovas and Medovas Pareeksha. And in the case of bone, the asti also, in the case of majja also, in the case of sucrose also, we can utilize the current evaluation methodologies or investigation methodologies to assess the Srodhodushti and to assess the Srodhovaigunya also. So it is very easy, or it is very objective, or it is very explainable, or it is very scientific that, and it is at molecular level we can examine the Srodhasas or the Adu or the Dushyas, and reciprocally we can go for the uh, dosha which is vitiated as a result of this dosha dosha. So definitely we can apply the current science and that evaluation methodologies in the assessment of Ayurvedic parameters. And this is, I have already mentioned that. So, with all these things, we can confirm the most likely diagnosis and exclude the potential diagnosis also. Mm. But in the case of the most important thing is that there is a blame against the investigations or the currently used by the clinicians that the what we can say the investigations are misused. In that way, some comments are there, some reports are there. So when as a clinician, as a clinician, we should have an ethical practice on the investigations also. Naturally, uh, to counter or to keep the dignity of the profession, we should have a culture on the ethical practice of medicine or Ayurveda. So, in the case of these investigations also, because some investigations are costly and some are very rare, and so that should be the practice should be ethical, and we have to select the appropriate test only. Unnecessarily, never go for a test because we can write so many in the battery of tests related to even under-level test also we can prescribe because the patient is not knowing. But never do that. You have to select the appropriate test only. Don't misuse the facility. So always we have to select the appropriate test only. And another thing is that uh, while writing the request for test, we have to mention the minimum clinical data we have to give. For example, if we write an ultrasonogram, then of the abdomen or the pelvis, then we have to write what are the clinical scenario that you want to do an ultrasonogram of the abdomen or pelvis of this particular patient. So, or you are writing for a CA marker of the liver. alpha beta protein of the liver. You have advised the patient to have a liver marker, the liver CA marker. Why? Because you suspect some nodular lesion, some lesion or malignancy in the liver, or you want to rule out some malignancy in the liver because the patient is having a history of cirrhosis liver or a alcoholic liver disease. So in that prescription, you have to write that the patient is having such and such condition, and his that gamma GT or the OTP or the liver function is impaired. So with illustrating that scenario only, you have to request for the test. So the test request should be appropriate. That is very important. And then the third most important thing is that test interpretation. That also is very important. For example, the level of PSR in different diseases, or the borderline reports, reports of even the markers or the immunomarkers or the hematological values if it is in the borderline. That also you have to interpret in an ethical and meticulous clinical way only. So test reporting is very important. Definitely, it needs some professional help, means senior help, and sometimes it needs some experience, some vetting. Everything is there, but we have to occur that supports, and the interpretation of the test result should be very accurately done. And the thing is that we have to identify some abnormalities we find which needs immediate intervention. If the patient, for example, if a patient comes to you with came to you with a fever, some chills, fever, and some chills, fever, and vomiting sensation, and he is very fatigued also. And on examination, uh, you done a CBC, complete blood report count, and you came to know that his total WB is 30,000. So then you have to identify that this abnormality needs some medical, means some immediate attention, because there is a toxic okay maybe in the body. So it needs more evaluation. We have to go for a culture of the blood sample, or so many other things we have to think about. So in that condition, anyway, the patient needs immediate attention. So you have identify either the abnormality or the test report which needs immediate attention. So in the case of these cancer markers also, if the PSA is the patient is having some urinary symptoms, some urgency or frequency, increased frequency or something else that, and on examination there is some that your PSA is somewhat high, like 30 or 35, then there is an urgency in that case, because the PSA, if the PSA is in that level 35 or 40, then there is a possibility, high possibility of malignancy in the prostate gland. Then you have to rush the patient to some urologist or somewhere else where the proper attention should be given immediately to save the patient. So this test report, so identifying the abnormalities which needs immediate attention or immediate intervention should also be noted by the clinician. So these are the things that you have to be kept in mind. And now we can come to some. These are the general importance of investigation in relation to our uh, clinical practice and the system. So, in nutshell, we can say that 2 points are very important up to this discussion. The first one is the importance of diagnosis. That is very important, very very important. Once again, I emphasize the importance of diagnosis. So always you should have a diagnosis before writing a medicine for a patient. That is must. That is Veda. Eh? That is the first thing. Then what are the utilization, what are the utilities of this investigation in the diagnosis or in the Ayurvedic diagnosis is discussed till now. Now we can go for some systematic investigation which can be done in our general practice. See, basically, uh, I am not happy with this whole presentation. Why? Because that diagnosis and investigation is a very vast area, and if say very frankly, it needs hands-on also. Because without seeing the patient, some of the investigations or some of the things needed cannot be occurred also. So that is my experience from my students and all. Uh, but anyway, we can have a glimpses of the diagnosis and investigation, and some general investigations what we will do in our clinical practice or daily practice can be discussed, and you read and you do, and again you read and you see the report, see the interpretations, and if at all you are having doubt, discuss with the peer group, discuss with the seniors, and you get your ideas, and in that way you can improve. Anyway, you can improve with all these things with this minimum or short information from my side. And now I started with the investigations in musculoskeletal disorders. Why? Because as far as Ayurvedic doctors are concerned, I don't know. This is in Kerala scenario. We are getting the number of when we do a statistics. The if we get 100%, if we consider 100 patients, most of the patients, that means I think nearly 50% of the patient will be from musculoskeletal disorders only. And the remaining portion of patient, 50% will have sharing all other systems like neurology, skin, gastrointestinal, even respiratory, and other systems of patients. But in musculoskeletal patients are more to Ayurvedic doctors. And so if a patient comes to you with a musculoskeletal disorder, mm, what are the investigations that you have to give to that patient? What is the rationale behind that? That is the thing. And in this area, there are so many differentials also. As you know, in musculoskeletal disorders means it is a group of disorders from inflammatory to infective, degenerative, and so many other things are there. So but anyway, nowadays we see infective and degenerative combinations also. A patient with degenerative knee joint will get some uh, that inflammatory conditions, some infections also. And usually, I think now the reactive arthritis group is increasing more. And when we think about the rheumatoid arthritis, the number of patients are comparative when compared to the olden days. Now it is becoming less. Anyway, there are many group of disorders in which inflammation or infection are the basis of the pathology, and so in almost all the patients, we have to give some hematological investigations, some acute phase reactants, some serological investigations of immunomarkers. Then, what are the hematological investigations we have to do? For example, the HB, the hemoglobin level of the patient, that is very important. As you know, in the case of hemoglobin, in some patients, for example, in rheumatoid arthritis patients, the low HB will be a part of the, or it is a sign of the rheumatoid arthritis because of due to some mechanisms in the pathology. In the pathology of the rheumatoid arthritis, there is a mechanism which reduces the hemoglobin of the patient. At the same time, that in that group, some collagen diseases like SLE, I have put some examples only. It is for discussion only because it's a very, very long story. It only takes 2 hours that discussion. But and in SLE, there is a possibility of hemolytic anemia also. in systemic lupus erythematosus, that there is a chance of hemolysis also. So in that conditions, naturally hemolytic anemia also will be a possibility. Anyway, generally we will get a low HB in that rheumatoid and SLE and in multiple connective tissue disorders. Right. But in the case of seronegative, it may not be in that level. So anyway, HB is having an importance in joint disorders, inflammatory joint disorders. Then total leukocyte count or TC, we will call it as TC, total count, and total count will be slightly increased in acute inflammatory arthritis. In acute inflammatory arthritis, in say monoarticular or in polyarticular conditions, if the condition is acute, then due to that acute inflammation, naturally the total count will be slightly increased. You know that the total normal count will be 4,000 to 11,000, and it may be 11,000 or 12,000 or in that range only. That also most probably we will be seeing in the acute rheumatoid arthritis and acute this reactive arthritis, and even some monoarticular septic arthritis. Also, we will be seeing an acute uh, that leukocytosis. And in that leukocytosis, we will have a neutrophil that increase. Means neutrophils will be almost neutrophils will be increased. But in the case of some chronic infections and some other conditions in which that lymphatic channels will be that lymphangitis, filarial or non-filarial lymphangitis, the lymphocytes will be increased. So that is the difference. And the thrombocyte also is having some role. Thrombocyte also is very important, and if the patient is having some patients will be presenting with a systemic disease, as the presentation will have a joint manifestation also, even including the malignancies also, including the hemato-oncological conditions also, the patient with the blood cancers like leukemic condition also. The first presentation will be joint pain, like the Amavada or the of the plan or textbooks. The patient will not be able to move, like that all the joints will be inflamed, and fever will be there, amerekshanas will be there. In that condition, that the difference in the blood count will be observed. And this is the most important thing in musculoskeletal disorders, because ESR and CRP, these are the acute phase reactions, because they will be responding very immediately to the acute phase of that inflammation. As a result of this acute inflammation, what happens is the ESR level will be increased. Mostly in the major joint disorders like rheumatoid and it will be active SLE, active rheumatoid, active collagen diseases. This will be nearly 100, or anyway it will be 90 to 120. So the interpretation of ESR also is very important. ESR will be elevated, but how much it is elevated will be deciding the differential diagnosis. So the level of elevation of ESR is very important. Anyway, ESR will be elevated, but in the active rheumatological conditions like rheumatoid arthritis, that SLE, or multiple connective tissue disorder, acute disorder, that will be around 100. And CRP also. CRP, that it is a protein, C-reactive protein, which is a inflammatory marker, that also will be elevated. So these are the two acute phase reactants which will be elevated in the joint musculoskeletal disorder of this active origin. But in some other conditions, it will be normal, because like SSA, that seronegative spondyloarthropathy, the ESR will be almost normal, not elevated. ESR will not be that much elevated if at all any underlying pathology is there. So, ESR and CRP will not be elevated in seronegative spondyloarthropathy. And then comes the serological markers. Serological markers can be, otherwise we can call it as immunomarkers. Serological markers or immunomarkers. So these are very important in the diagnosis of musculoskeletal disorders. In this rheumatoid factor, or RF factor, rheumatoid factor RF, this is a common test. Which we can say that old test, because since long we know that rheumatoid factor test is available in our hospitals and all. So rheumatoid factor is a immunomarker. It's an agglutination test, which is an important test in the rheumatoid arthritis. But it not only see in rheumatoid arthritis, in other conditions also it occurs. But a majority of the patients will have this rheumatoid factor positive. But with if rheumatoid factor negative means, it doesn't mean that the patient is not having rheumatoid arthritis. So we cannot, the specificity of the rheumatoid factor test is very, when we compare, it is less, but the sensitivity is more. And you have an idea regarding two terminologies in test reports. The two terminologies are, one is specificity of the test, and the next one is sensitivity of the test. The specificity of the test means a test will have specific specific what we can say, nature, that if the test is positive, then almost clinical condition is confirmed. For example, in the case of anti-CCP, in the case anti-CCP is, if it is highly specific test. If 96%, it is specific, but rheumatoid is having less than 60% specific. So if anti-CCP is having 96% specificity, that means if the patient is having anti-CCP positive, the means 96% of patients will have confirmed case of rheumatoid. But so that is called the specificity. But the sensitivity is 76% only. Means it will not sensitize all the group of patients. But if at all it sensitizes, the specificity is highly appreciated. But in the case of rheumatoid factor, the specificity is less, but the sensitivity is more. So, in some other inflammatory conditions also, we will get rheumatoid factor positive. For example, in the time of chikungunya and this dengue fever outbreaks, we got many patients with rheumatoid factor positive without any classical signs of the criterion of rheumatoid arthritis. So, in that condition, there is a responsibility of the clinician, that we have already discussed earlier, that test report, that the reporting of the interpretation is very important. So in that condition, we should interpret that the test is false positive test. It is not it is not genuine. It is false positive test. Sometimes false negative test also we get. So false positive and false negative test we have to tackle. We have to handle. We have to interpret very carefully. So this is about specificity and sensitivity. So these are the two terms to be kept in mind in relation to test reports. Test reports. So rheumatoid factor. Then comes the antibodies to cyclic related proteins. That is called the anti-CCP. It is a very recent test, not too recent, but comparatively it is a recent test which confirms the rheumatoid arthritis very clearly, early, at an early time when the synovitis of the joint start, the anti-CCP that will be responding. So we can identify or we can detect the rheumatoid um, arthritis very early. That is the benefit of the test anti-CCP. And another thing is that another prognostic importance is that if anti-CCP value is very high, like 120 or 130 or 230, we will get that type of patients also. If that value is very high, then you can assume that the erosion of the bone tissue is more. So there is a relationship between the value, the titer value, and the erosion of the bone. So we can predict the complication also. So it is a very beautiful test in the diagnosis, even and the management of this rheumatoid arthritis. And another thing is anti-stabilize, ASO titer, as everybody knows, because it is a test which is in relation to or a test which helps to diagnose the rheumatic fever. Is traditionally it is doing, but in that test also some false positive test will be occurring. For example, many patients with some other system means infections also get positive that ASO. That doesn't mean that the patient is having rheumatic fever. So always the test report should be considered on clinical ground only. For example, if you are getting the Jones criteria for diagnosis of rheumatic fever, major and minor, then with this ASO titer, then we can positive, then we can say that this test positivity is in favor of this rheumatic fever. Otherwise, if the patient is having no criterion and no that criteria is not fulfilled at all, but the ASO is positive, then we can ask the patient that this is not rheumatic fever. It is a test negative positive, false positive result. You don't worry. In that way, you can interpret and you can clarify. That is about the ASO titer. And comes the most important test, anti-nuclear antibodies. Anti-nuclear antibodies, one thing, the values, the normal values, either you can go in the go and refer in the test books, or you will get in the lab that report itself. Why? Because the method and the kits they are using will be differ, and the reporting values will be also different mostly. So that is very simple. You can get it from the that report itself. So anti-nuclear antibodies. Anti-nuclear antibodies are a group of antibodies which help us to diagnose the connective tissue disorder, collagen disorders, etc.